Bit of news as well. Next meeting after this, June the 18th, we've got Dr. Lynette Simpson, who is lead at Health Psychology Unit at Leicestershire NHS. She's been on our group before, talking about counselling therapy, how to deal with anxiety with balance issues. She's going to be taking all your questions in 2 months' time on that subject. So that should be good. That's it. I'm going to shut up. All I'm going to do now is introduce Andrew Clements, who many of you may know as Mr. Balance. He's been, if you don't mind me saying, I think, is it 25, 26 years, Andrew?
I've been here for that long, yeah.
Yes.
I've been in the NHS now. It's coming up to, it'll be 30 years next year in the NHS. So,
yeah,
in the Balance Clinic, 20-something years, yeah.
I'd be right in saying you were instrumental in setting up the Balance Centre at the NHS. So that is brilliant, because it's I think one of the country's best resources. And Andrew also works privately with the London Road Clinic in Leicester as well. But the wonderful thing about Andrew, even though he's very modest about it, his use of plain English is brilliant to explain what's going on. We do get some experts who are tied up in all the medical jargon, but you're going to find today how wonderful Andrew is at talking in a language we all understand. So without further ado, we have members' questions at the ready. Rupal, if you can start us off, and all over to you, Andrew and Rupal. Thank you very much.
First question comes from Simon, who says, I know that my neck and shoulder being out of kilter plays a part in my vestibular migraine and balance, but beyond me observing my posture, do you have any neck or shoulder posture tips or hints when I'm feeling dizzy or tired and I can't really focus on helping myself?
Okay, well, I suppose that's quite common because as people get older anyway, people get neck problems. And if you've got a vestibular problem as well, they play off against each other in a negative way. So you don't want to move your head because your neck hurts, and you don't want to move your head because it gives wrong signals to your inner ear. So in that sense, it's best not to move your neck, and then that creates problems. So movement is good. So, and that's good for your neck, and it's good for the vestibular system. And being out of kilter means being out of alignment. You've got to watch your posture all of the time. Because it's no good just trying to put a posture on at a set time. It's really, you've got to try and maintain good posture all of the time. Otherwise, if you get into a bad position, you know, and you sit with your head tilted over because you're on the phone for ages, it will play up. Your neck will play up, and then your vestibular system won't allow you to do the sort of movement you need to do to free it up. So I suppose if the question was in relation to things like using a computer or working, that applies to anybody using a computer or sitting at a desk doing something. Even without a vestibular problem, you have to actually get up and move away from that screen within every hour and stretch and turn your head and move your neck and look at a distance out the window. They're all things for normal, I suppose, ergonomics to do with body posture and work positions. So you should be trying to be aware of your posture all the time. So that might mean having the best seat possible if you're going to be working. If you're sitting watching TV, not slumping down in a soft sofa, because all of those things will put your neck in a bad posture. And if you've got neck problems and or vestibular problems, it will make them play up. So I hope that answers it. It's actually, but movement is good. The neck likes movement. Neck joints like moving. The vestibular system needs movement. If it's not working properly, when you first start moving, it will feel wrong. But as anyone that's done rehab with me knows, I want you to keep your neck moving and keep in a good position.
Are there any particular exercises, Andrew, that you can recommend?
Well, I mean, if you're doing them for your vestibular system, they're the sort of rehab exercises where there's repetitive motion, whether it's up and down or left and right, so you're repeatedly moving your head. From a rehab point of view for your ears, you don't have to go to the end point. You don't have to go as far as you can. But if you're doing it for your neck, you do it slower and not so repetitive, and you go as far as you comfortably can and you hold it. So the exercises are different. So for your neck, you do it slower and go further and hold it. And for your ear, you do it a bit smaller, but more often and repeated is the best way to be aware of it. But your posture needs to be good. So if you're sitting, you need to be sitting with so you're erect. So whereas if you're slumping and you're slumped, you can't move your neck as far. I'm showing you now, that's as far as I can move my neck because I've deliberately slumped. Whereas if I sit straight, I can go all the way around. And if you're sitting slumped all of the time, then your tissues will get tight. The muscles and the fascia around the joints will get tighter, and you'll then it will be harder to go to the end point. So you've got to get into a habit of stretching your neck if you do have a neck that goes out of kilter.
Simon, sit up straight.
Sorry, I've just moved now. There you go.
Yeah, there you go. That's better. There you go.
Yes, it's hard to see. I see the names on here, and some of the names are on the screen. So I do. I was looking around for Simon before, but I couldn't.
Thanks, Rupert. I'm sitting up straight now.
Yeah.
Hopefully that'll help. And those exercises definitely sound good.
Thank you very much.
Amy has got a question. I have Meniere's disease and vestibular migraine with daily internal vertigo and fairly frequent external vertigo attacks. My ENT wants me to do vestibular physio on my own at home, but I've been informally advised by another ENT to wait until my vestibular migraine isn't so active or it'll make things worse. This fits with my experience. Do you have any suggestions with anything gentle that I can try that will help the Meniere's without aggravating the migraine?
Yes, that's quite difficult because there is this overlap between Meniere's and vestibular migraine, and quite often people can't delineate the two. Whether it's their Meniere's or whether it's a migraine. So the closer together they are, the harder it is to give you something to do. But normally I would say, one with Meniere's disease, the exercises should not trigger a Meniere's attack. It's as simple as that. So vestibular exercises and gentle head movements should not trigger a Meniere's attack. If they do, every time you're doing it, trigger a Meniere's attack, don't do them, which is what you've been told. So it won't be the exercises themselves that are triggering the Meniere's, but maybe the Meniere's is in such a sort of unstable situation that anything's triggering it, and it just seems to be the exercises that do it. So if the exercises definitely trigger Meniere's or definitely trigger a migraine, I would say you don't do them. But with relation
they're triggering the migraine, they're not triggering the Meniere's.
That's fine. That's what I was just about to come to.
The migraine.
Yeah. So gentle, if it's not the migraine, you can do gentle exercises with Meniere's, head movements, walking, sort of just gentle and slow activity. For the migraine, it's different. We don't want the exercises to trigger the migraine at all, because migraines are different to Meniere's, and the rehab program isn't aimed at really treating migraine itself. So really the migraine needs whatever treatment program you're on, whether it's diet or control or medication or whatever. The migraines have to be diminished before you try exercises that might provoke them. The exercises most provocative usually for migraine are the ones which I normally like, which is looking at targets, moving your head, looking at something, or moving your eyes. Well, with migraine people, I say don't do that element. I often just have them doing exercises with their eyes closed, because eyes closed is good for the ear anyway, and then eyes closed isn't provoking the migraine. So you can do gentle movements, whichever rehab program you've got, as long as you're safe, you can do with your eyes closed. Then you're not getting the visual stimuli that might upset the migraine.
That will help with the Meniere's, will it? Doing them
That
with
will
my
help with
eyes
Meniere's,
closed?
yes. It won't stop a Meniere's attack, but it will help with recalibrating the responses to help the other symptoms from Meniere's because you've been having attacks.
Okay, brilliant. Thank you. I'll do that.
Thanks, Amy. We've got a question from Linda, who is a new member. Welcome, Linda. I'm not sure if you are here. Can't see you on the screen. But Linda's got a question. She says, I was informed by somebody in the audiology department at a different hospital that because I was doing such long walks most days, say 5 miles on average, that I could be doing too much and that my brain could become overstimulated. As I said, I become very tired on my walks, but that I took my time and sat down at regular intervals. I use 2 walking poles to keep my balance, but even though I do all of this and the exercises, I do not appear to be getting any better, Andrew.
Okay, so that's, well, again, it's if I say most of that, I would agree with, except saying that if you can do a 5-mile walk, that is good. That's a long walk. So that means you're able to move, so 5 miles is going to be at least, I mean, I did that the other week. It's probably going to be a good hour walking to do 5 miles.
It takes me a long time.
Sorry?
It takes me a long time because I sit down a lot.
Okay, but that's fine. So we don't mind having rest. So from a vestibular point of view, what the audiology department would have been implying is short bursts of activity, then a recovery phase is what's good for the ear. So, and I would agree with that. So, but if you can do a longer walk with the breaks, that's absolutely fine. The thing is, what you've got to be careful of is fatigue. Fatigue will make you cope less with your vestibular symptoms. So
Right.
if you're walking too far and getting overtired rather than overstimulated, I'd say overtired and fatigued, then you won't cope as well with the vestibular symptoms. So it might be worth looking at doing slightly shorter distance, or maybe put a few extra couple of breaks in, because if you can do 5 miles, that is good. And I don't think it's overstimulating you, because you haven't described a vestibular upset there. You just say it's not getting better. Whereas if you said, I walked 5 miles and then my head is spinning and I have to go and lie down for a day, that's been overstimulated. Whereas if you're just feeling tired, you just got to have more breaks, maybe for a bit longer, but keep doing it. And if you've been doing it regularly, it probably isn't overstimulating your vestibular system. Whereas if you walked 5 miles, say, through town or in shops, then that would overstimulate your vestibular system. So I think enjoy the walks. Using poles is good. I quite like the walking poles, but you might need, when you say you're not getting better, what needs to be challenged is what you mean by that. What isn't getting better? And that's what the exercise has to target. So we can say you can keep up with your long walks broken up, but you might be needing to challenge something else to target what the problem is. I mean, if, for example, I don't know, say the problem's bending over, putting your shoes on, and that makes you really dizzy and off balance, walking 5 miles isn't going to help that as such.
No.
If that's the problem, then you might need exercises to challenge that element. So that's where the therapist you're working with has to build something into your program that challenges the problems that makes you say, I'm not getting better. So it depends what you mean by that.
Well, I had COVID before Christmas.
Oh, okay, yeah.
And I've got an acoustic neuroma. Okay. And they believe that the two are connected. That I had the vertigo attacks were connected to the COVID, which then left me with permanent vestibular neuritis.
Okay, so there's some of the terminology they've left you with there is a little bit, if I say wrong, I'm not criticizing what they've said, but so if you've got an acoustic neuroma, that's a separate entity. That's I don't know how much they've told you about it. It's a swelling on the nerve from your ear to your brain.
Yeah.
So that's an acoustic, but you would have had that probably for a long time, and they'll probably be checking that every 6 to 12 months to make sure it doesn't change size.
Yeah, they said it hasn't grown.
That's good.
But they said that the COVID with the virus, with the COVID virus, it could have attacked. It could have attacked it, and like a suspension bridge, it could have pinged a couple of the wires out.
Yes, it could have, but that would apply to anyone that's had the COVID attacking the nerve. So the acoustic neuroma is almost like a separate entity, and it's there, and it's something that needs monitoring. But if it hasn't grown, that's great. Having had the COVID, that's like a new insult, a new injury to the nerve anyway, and that could upset things, is what they probably mean. But that then should respond to exercise. You should be able to, with correct exercises and moving, that element should be recoverable. But if you've got long COVID symptoms, which are the after effects, that just slows everything down getting better, and it adds to the fatigue. So whereas maybe before COVID you could do your 5 miles relatively easily, after COVID especially, the fatigue might be much worse, and your balance might be worse, and that doubles the fatigue up. So you've just got to respect it. So keep doing the things you want to do, but the COVID element, that whatever damage that did to the balance system, that bit should be retunable with exercise, and the acoustic bit will just be monitored for a long time to make sure it's not changing size.
Okay, thank you.
Right. Thank you. Thanks, Linda, and welcome to Life on the Level. Got a question from Alison as well. I'm nearly 2 years into a diagnosis of complete bilateral vestibular failure with oscillopsia. After 2 short courses of physiotherapy, which ended nearly 6 months ago, I am still unable to go out without holding on to someone to remain steady. I constantly feel I'm living and walking on a trampoline. Is there anything that can be done to help me regain my independence? I've been left with vestibular exercises to do and a pair of elbow crutches, but these don't provide enough stability. I don't have enough balance to control a walker, as any uneven surface causes me to wander. Can you give me some advice, please?
So, yes, I mean, bilateral vestibular failure is one of the hardest things to treat in the vestibular diagnostic categories, really. And I think I can see Alison is there then. So you do know it is complete failure. You've been told definitely both ears aren't working.
Yes.
Okay.
Yes.
Because that does leave you with oscillopsia, which is eyes bouncing up and down every time you move your head.
Yes.
So the world moves with every single movement you do. The world moves.
Yes.
Is that right?
Yes. Yes.
So it's the hardest to treat. It's the slowest to get better. But I find it frustrating to say you've had 2 short courses to help someone with bilateral vestibular failure. You need to be doing exercises and balance exercises for a good 18 months to 2 years.
I have been doing them for a year and a half.
Okay, so getting towards that time frame.
And I'm getting nothing from them.
So when you've got to keep challenging your balance, because what happens with the normal rehab exercises we use, if you haven't got, because bilateral failure means both the ears aren't working at all, whereas people with things like Meniere's disease, one ear might not be working, but they've got the other ear to cover for it. But so with bilateral failure, when you're perfectly still, probably you feel okay, and you probably don't.
It depends what I'm sitting on. Even the surface I'm sitting on. If I'm sitting up, like right now, I'm on a moving chair, and that's fussing with my head as well, because the chair it's a swivel chair. Certain
but that would mean to me then you need to choose, for example, not a swivel chair. Because yes, if you sit on a swivel chair like I am and you just do a little movement like that, for you that will create quite a strong sensation, and your eyes will move. So but from a rehab point of view, you have to keep the exercises up, or you have to keep exercising, not necessarily the exercises, depending what they've given you to do. But what happens over 18 months to 2 years, your brain will reprogram itself to try and give you the eye movements you need to feel a bit better. I mean, you can't be fixed. It's actually, you can minimize the symptoms a bit. And I've seen quite a few patients at my hospital with bilateral failure, but I have kept them on, well, for well over 2 years, 3 years, not seeing them all the time, but they've got contact with me. And I've, you know, some of those I've got back driving, which, you know, when I first saw them, they walk down the corridor like they've had like 20 pints of beer. They're all over the place. So you're probably in that category. I used to hold onto someone's arms, but now a lot of them do go out walking, but they can't move their head when they're walking. They can't look around the countryside. So you need to keep practicing the things you want to do, because your brain, it needs the stimulus so it can sort out what it needs to do. So with bilateral failure, we can't give you specific exercise to make it happen. Your brain has to find a way to make it happen. So the more activity you do, safe and controlled, so you're not dangerous, the more you're doing, it gives your system chance to improve. But with bilateral failure, you will not get back to, see, with normal vestibular problems, I'm aiming for 80% improvement. That's what I aim for. Anything above that is a bonus. But with bilateral failure, we can't put any figure on it, and we just hope that you get as good as you can get. But as I said, if you keep going, you know, with walking, trying to walk with people, keep doing it with, you said crutches you're using. Have you tried poles, or do you
I've tried poles. I've tried a walker. It's because any uneven surface, I don't have the balance to control a walker.
No,
it's just, I walk. It takes me for a walk rather than me taking it.
Yes, but you're not falling over them. So
the crutches I don't have. It still doesn't give me enough stability that I could go out. I'm nearly 2 years without going over the door on my own. I can't go outside without holding on to another human being, and I just want to be able to do that, just to go out myself.
But that's a thing you got to work on then. But I would say avoid at the moment uneven surfaces.
Because but you try doing that when you're walking along a pavement. A pavement is naturally uneven.
It is, but you need to find somewhere. You need to find somewhere where you can go and practice. So we take away all of the high risk things. So yes, I know what you're saying about pavements. So when I say you need to practice walking, you need to be going somewhere where it is nice and flat.
I go into the supermarket. I can walk around inside a supermarket.
No, I wouldn't call that safe. I'm talking that's out. That's shopping. I'm talking for exercise. You need to find somewhere really safe, whether it's a patio at someone's house or at your place. You need to be finding somewhere that you can go to with someone else, which is nice and flat, so there isn't the uneven surface element, and you can practice walking with your crutches, or a walker if you've got one, to get better at it, because you won't be able to cope in the normal street or in shops if you can't get out your front door, if that makes sense. So you've got to find somewhere really safe that you can practice and practice and practice, and then you'll get better at it, and then you've got to build it up, and that's what the therapists need to be doing with you. You know,
I don't have a therapist. I've been discharged by everybody. I'm not seeing a consultant, an audiologist, or a physiotherapist. Physiotherapist told me there's nothing they can do for me, and that's me. They left me with the crutches and walked away.
It's hard to answer that. But so what you need to be hearing is you need to be with someone else so that you're safe. Finding somewhere that you can practice either the walking with crutches or with someone's arm, but not using their arm too much, or using the walker to build up your balance, because otherwise you're always trying it in situations which are too hard for you. So it won't get better in a too hard situation. Or if it does get better, you won't see it because you feel so unstable. So you need to be practicing somewhere where over time you will see little improvements, and then you need to build on it. But with bilateral failure, your brain can find ways to do it. It needs to be given the chance. So what the therapists might mean is that, you know, they can't add anything else in, but they need to be saying to you, you've got to be keeping to try things somewhere safe so you can repeat, because it's by repetition that your brain learns. Because what you haven't got is something called a VOR, a vestibular ocular reflex. You haven't got that. So normally as therapists, we're trying to retune the VOR, but you haven't got one. So your brain has to learn how to replace the VOR with its own mechanisms, which it can do, but it takes 2 years, and there's no specific one exercise that teaches it. Your brain has to find the way. So you've got to give it movement and give it chance to challenge so it can find it out. But it is hard. And if you haven't got the support, that makes it harder. But
okay.
Well,
thank you for that.
Hopefully you've got some support here in the group and great advice there with Andrew as well. Moving on to Debbie then, and Debbie's got a couple of questions. The first of which is about when you improve after exercises and then your symptoms return. Should you continue with the same exercises or change them?
Well, is Debbie there? I can't see Debbie. It depends on what you mean by that. If you get back to being close to normal, and then you stop the exercises, and then at some point your symptoms come back, yes, you can go back to the exercises you were doing. But if you're doing the exercises and improving, and for some reason the symptoms come back, should you use the same or change? It depends if the exercises are anywhere near normal activity. If they're just simple sitting, moving the head, that isn't real life. I mean, to me, we're always aiming to be able to walk and move your head and do normal things. So the exercises have to progress towards that to allow you to be more normal. If you're just doing really easy exercise, and then in real life you're doing more challenging things, the exercises have to be harder. So I'm not sure if that answers it. But if you're talking that you've got quite good and you've stopped the exercises and then your symptoms come back, yes, you can go back to the exercises you were doing.
Is that Debbie is here, I understand. Where are you, Debbie? Oh, there we go, Debbie. Yeah.
Yes, it does, because I find when I get better, and then all of a sudden it gets worse, and to the point I'm having to lie down.
Okay, so what's happening there then? So that must be, you must have some sort of attack of symptoms.
Right.
So there's something, because if you're fairly good and then suddenly it gets worse, you need to work out, why did it suddenly get worse? Was it because, for example, if you had BPPV, it might be you've been fairly good and then you get an episode of BPPV come back and that gives you an attack, and then your symptoms come back. So then you need to get the BPPV treated or treat that yourself, and then maybe do the exercises if required. But if it's just that you haven't got BPPV and your episodes are suddenly worse, it might be with people like many years or migraine, it might relate to what you've eaten or stress or tiredness. So then you've got to address those elements. But otherwise, if you can't put a trigger on it and the exercises have helped, yes, you go back to what you're doing. But as a general rule, over time, they should be more challenging. They should be more towards to allow you to do what you want in real life.
Okay, that's good, because it seems like I've just plateaued.
Okay.
Yeah. But
yes, because plateaued's a different system. Plateaued, if you've plateaued and it's at a good level, it's a high level, I don't mind that. But if you've plateaued at not a very good level, then the exercises need pushing. Right. So if they've got easy and you've plateaued, the exercises have to be more challenging. And in simple terms, they have to be making you do the things you don't like doing in a controlled way. They have to provoke, well, they will provoke symptoms, which is what the easy ones would have at the start. And then they got easier. So at that point, they need to be made more challenging.
Okay.
Whether, safely, but more challenging for people that aren't under therapists and things.
I'm seeing you on the 25th of May with Professor Ray. So I'm looking forward to that.
Hopefully get lots more advice. Debbie, did you want to ask your second question about being visually weak or strong?
Yes, I sometimes find, I find a lot of times that if I just do a simple exercise of following my index finger in and out and side to side, it does seem to help, even though my eyes feel like they're got cramp. I know that sounds
okay. No, I mean,
weird.
It's not a sign of being visually weak or strong. You found a mechanism to break the cycle of the dizziness, which is fine. So if you're looking at your finger and moving it in or moving it out or moving it left and right, if you're looking at it, you're using your brain, your cerebellum, to control your eye muscles. Yeah. So the cerebellum overrides the vestibular system. So your cerebellum wins. So that the vestibular system is saying, oh, you're dizzy, but your cerebellum, you're working your cerebellum. So it says, no, concentrate on the finger. And then, so that will override the dizziness. So there's nothing wrong with that. It's not good or bad. And if it works, you can use it as a treatment. But if you are a migraine sufferer, it would probably give you a migraine. So that's where, people can try things like that. But if anything makes the dizziness feel better as a treatment, you can use it. There's nothing dangerous in it. But a migraine sufferer trying that might get a migraine doing that.
Right. Oh,
but
yeah.
So that's fine. So you can do it. So if you want to break, some people say, and in fact, a few people at the hospital have said it to me, when they're at a better level, not when they first started, when they're at their worst, but when they're getting better, if they have a really dizzy episode, something makes them feel really dizzy, they find really almost shaking their head really fast. Actually, I know they find that actually helps, and I thought about that, and you see it in cartoons, don't you? Sometimes when something like Tom and Jerry, and they go and shakes their head like that. Well, what that does, it gives a very strong vestibular stimulus doing that. So so it only works if you're fairly good, because then that's very sudden, strong vestibular stimulus overtakes the other one, and then when you stop, it just resets it. Whereas if you're not at a good stage, it'll make you feel worse. I mean, it's not dangerous, but most people wouldn't do it because it would actually make you feel worse. But so enough people have told me it that I tell other people now, and it works for some people, but they've got to be at a fairly good level for it to work, because if you're at a bad level, it will just make you feel worse.
Okay.
Yeah, great.
Thank you.
Thank you for that, Andrew. I'm not sure about that. It's making me feel quite ill just thinking about doing that, but I might try it when I'm feeling better. Tracy, I know is here as well. She's got a question about BPPV.
Oh yes, I get it.
I understand that BPPV occurs because we generate crystals, rocks, things, then they fall into
on this page.
She's there, and then fall into a place that they shouldn't, which means that we get dizzy. Then eventually they dissolve and disappear. Her question is about how do we stop them forming in the first place? Is it related to diet, vitamin supplements needed, perhaps, or hydration? Prevention is better than cure. So what can we do to prevent?
I can't see Tracy. Where is she?
Yeah, I'm here. My camera's not working.
Ah, you're there. Okay. Are you one of our patients from the Royal?
No.
Oh, I say good, because I would hope none of our patients would say that, because we've all got the crystals, all of us. And this is, so when I see people, and I haven't got my charts here at home, but I did bring my little inner ear to show people. We have all got those crystals, all of us. They're part of our body, and they're in, this is my left inner ear. And
can you move it up to the camera a bit more, Andrew? Just
okay, so it's my left inner ear. This bit's the hearing bit, so don't worry about that. These are the spirit levels. Looking here. The crystals are in this bit here, called the utricle. It's the utricle and saccule. We've all got them. They're like little stones. They're made of calcium carbonate, and they're little stones. And in people that haven't got BPPV, they're all stuck together in a jelly. And they're made of the same material that kidney stones are made of. It's really hard. And their real name is otoconia, which means ear stones. So we have all got them, and they're part of the human body, and they've got a purpose. And their purpose is that because they're in a jelly, when I bend my head forward, they all fall forward in the jelly, in this bit here, they all fall forward, and it bends the hair cells, and it tells my brain that I've bent my head forward and looked down. If I look up, they all fall back in the jelly, and it tells my brain I've looked up. So they bend the hair cells. So that's their purpose. They're part of the balance system. When you have BPPV, something, and it's usually a virus, has damaged the vestibular system, and some of those little stones or otoconia or crystals, and I don't like the name crystals, even though they are crystals of calcium carbonate, because they're stones, they've broken out of the jelly because it's been damaged, and then they fall into the spirit level. So they fall from the utricle into the spirit level. And then when you bend your head forward or bend your head back, they move in the semicircular canal because that's full of fluid. So it's like sand in a spirit level. You've got some sand in the spirit level and you tip the spirit level up, and gravity makes the sand move. Gravity makes the crystals move because they're heavy, and they roll down the spirit level, and that makes you really dizzy because it makes your eyes roll, and it gives you a nystagmus. So people with BPPV, when they change their head position and they lie down in bed, or they bend over to do something, bend something off the floor, gravity makes the little crystals move which are in the wrong place. They move and the fluid moves. That makes the hair cells move, and that makes you feel like you're spinning. So so in relation, so to say what you said there, now I'm looking at the question. So we don't generate the crystals. They are in the wrong place, and that's why the treatment is to put them back with something like the Epley maneuver, where we move the head and we roll it round to tip them back to where they've come from. Or we can do something called a Sermont maneuver, where we fling them back into the right place. Or you can do exercises at home where the Broft exercises, where you sit and lie down and then turn your head and then sit up and then turn the other way and lie down, and that washes them through. So the treatment is aimed at trying to get them back into the right place. But when they go back into the right place, they don't go back nicely into the jelly. It's like dropping a stone into a bowl of stones. It might wedge in and then it's good, it's stuck in there, but it might just sit on top of the stones, and then 2 weeks later it falls out again. So over time they do dissolve, which is what you said. So that's why sometimes they just disappears on its own, but otherwise we do try and treat it by putting them back into the right place, but they can come out again. And whatever damaged the ear can make other ones break loose. And as you get older, they do break loose anyway. So they're part of the ear. We've all got them. So how can we stop them forming? Well, we don't want that, because they formed when we're if our childhood. Is it related? Now, there's talk of vitamin D being very good for helping them. People with BPPV often supplements of vitamin D to have the normal vitamin D is really useful. And I think if you're deficient in vitamin D, there's more likelihood that that area can be damaged and they can break loose. So vitamin D is worth looking at. Hydration, well, hydration is just good for health. So whether it's specifically good for BPPV, I don't know, but it's good for health. And then to prevent it, well, you can't, once you've had BPPV once, there's the figures are, you can either look, there's two sets of figures. Either there's a 30% chance it will come back at some point in your life. So there's 1 in 3 chance that it will happen again, whether it's in 5 months or 5 years. Or there's a 10% chance per year, once you've had BPPV, it'll come back. So that usually means within 10 years, you'll have another episode. But some people have BPPV every few weeks. So,
yeah, I tend to have it every year.
Yeah.
But then throughout the year, because it's so petrifying for me, the feeling.
Yeah.
I worry about getting it. So I just like, now you've got me thinking, I need a syringe with some jam and I'm going to shove it in my ear.
Like, no, I wouldn't try that. Because this structure that I'm showing you, where the crystals are, is underneath your brain, and it's encased in bone. So it's nowhere near injecting it with jam.
Don't worry, I won't.
You'll just clog your ear canal up and then have to explain to a doctor why there's jam in your ear.
But there's no sort of, there's no sort of, I know that there's a surgical procedure that you can have done that kind of blocks.
Yeah, what the surgical procedure does is, I mean, and it works. All the doctor, most of the doctors that do it are very good at it. And what they do is they block the posterior canal so the crystals can't get into it. But it's quite a big operation. This is quite a long way in. You have to drill through a lot of bone. And you will need rehab afterwards. So there's always risks with an operation. It's a hearing, there'll be very small risk, but there's always risk. There's risk of infection, and it's a big operation that it's close to your brain. So if you only have it once a year, I don't think our doctors, with those sort of, if it's that infrequent, I know, but what happens is you're aware of it the whole time. You change your life to. So are you keeping your head really still all of the time?
It happens to me when I roll over in bed.
Yes, because that's when you roll over in bed is the position that actually puts that spirit level in the perfect position. So, and when we do the test on you, that's the position we put you into. We put you in the position that you'd roll with your head, you see. So, but do you get it that you can roll over in bed most times, but every now and then you have it?
Yeah. Okay.
Then how do you fix it?
Then I do that procedure with the sitting up and moving my head, and that always fixes it.
Okay, so that's really good. So you would not be a good surgical candidate because you can fix it yourself. The thing is, you're worried about the feeling of it. Now, it does give a very strong sensation of vertigo, but the fact you can fix it is really good because you know what to do with it. So understanding what it is can sometimes make it better, because the thing with it is BPPV, even though it makes people feel really horrible, it's just a benign condition with, and it's not serious. It just makes you feel horrible for a few seconds when you roll over in bed because some debris moves in your ear. So the fact you can fix it, you should be pleased that you can fix it, because we have lots of people that need maneuvers every 4 to 6 weeks and it makes them feel horrible. We've got this new chair we strap people into and roll them around on the chair to try and move the debris. So in a way, you should be pleased that you can deal with it. And if I say try and change the mindset around the symptoms, have a look at a few videos online about BPPV and just see what it is. And when you feel horrible, all it is just a few little stones or crystals moving in that. It's like think of sand in a spirit level. Tip the spirit level up, the sand moves. That's all it is. So all you've got to do is put the sand back into where it's come from, which is what it sounds like you're good at doing. Because a lot of people can't do the brand draft exercises because it makes them feel so horrible. They hate doing it.
There's a great video that Michaela's done online as well. It's on YouTube about the actual exercises. So worth looking that up. And I think Michaela's on here somewhere. If you could just send a link to that would be quite cool. Because it's a really good video.
But there's also some good videos showing the BPPV, like with cartoon forms showing, what happens when you lie down and the little debris moving. So there are some good videos so you can, because the more you can understand a problem, the easier it is to deal with. It doesn't mean it fixes it, but it's easier to deal with. And I suppose that's what I do try and do, is get people to understand why they're getting symptoms.
All right. Thank you, Andrew. Thank you, Tracy. Is Richard here? Richard Smart, are you here? Because we've got a marathon number of questions from Richard, and hopefully we'll get through some of these, Richard. Shall I ask the first one and then get you to ask some of the others? Is that all right? Is that good for you?
Well, can I? I've got his questions here.
Okay.
Can I go to the third one first, which is, can you explain why walking in the dark is so difficult with these vestibular conditions? Because that, in a way, if I say that's an easy one to answer, that's because when you're walking in the dark, your brain is mainly using your vestibular system for balance. So if you've got a problem with your vestibular system, moving in the dark will be the biggest problem, because when you're moving in the dark, your brain can't rely on vision because it's not there. And because you're moving, say walking, it can't really rely on your ankles, hips and back as much, because the information from that is less because you're on the move. So your brain will look to the inner ear to say what's happening. And if the ear's not working properly, that's when you'll feel bad. And in fact, if you were walking on the sand in the dark, you'd be even worse. But which is what I make some people aim to do if they live near a beach. So it's a good exercise to try and help it retune walking in the dark. As long as it's safe, as long as you're not falling over, you will be all over the place probably. If it's pitch black, you'll be all over the place. But if it's darker, it's a good exercise. Moving in the dark is a great exercise for vestibular symptoms because it makes the brain focus on the vestibular information because it can't use your eyes. So movement in the dark, I always build into people's exercises. Because Richard had mentioned it, why is it so difficult? In a way, it's not difficult to explain. It's because that's what you're using at that point. You're using your ears, and if they're not working very well, you won't feel very good. But actually, if you keep doing it, it will get better. You just have to be careful and be safe because you might veer off. So don't do it at the top of the stairs, walking in the dark, because you might not end up where you think you are. So you just got to be very careful. But I do have some people, in fact, I try it myself, walking the dog in the fields. I set off in a straight line and I close my eyes and I try and walk for 30 or 40 meters with my eyes closed. And then I open them and see where I've ended up. And I've almost been in the river twice because I couldn't tell that I must have just drifted off a little bit one way. Because so you might not be in a straight line, but walking with your eyes closed, not 40 meters. I'm just talking, a bit in the house is good. And we often, as a test, get people to march on a spot with their eyes closed, and they'll turn often towards the ear that isn't working properly. That's called the Unterberger's test, and they'll drift around. So you just got to be careful. As long as you're not falling over, we don't mind you drifting and looking drunk. We don't want you to fall. So that's the walking in the dark. I have a physiotherapist who's given me neck exercises for my neck. Well, okay, but as I said earlier, neck exercises are, if they're for your neck, that means they'll be slow and not repetitive, and they'll be to end point. So that's not really going to work your ear so much. Whereas neck exercise, moving your head, that's good for your ear. Neck exercise, stretching like that, that's good for your neck. So if you're doing that, that isn't going to do anything for your ear. So, but then I'm not sure what you mean by, I'm already seeing a VRT. Well, if you're having VRT, they should be giving you specific exercises for your ear. What else can I try? Acupuncture. Well, acupuncture's okay. I've had some people who've had vertigo and say it's helped their vertigo. I don't fully understand acupuncture, but I don't not believe it. If enough people have said it makes a difference, but I don't know how to tell if the acupuncturist is doing the right things. But as I see, if you're getting vertigo with a medical condition, if the acupuncture can change the medical condition, it might help. But if you're getting symptoms of imbalance because your ears are out of balance, the treatment's got to be to make your ears come into balance. And that's what VRT is about. So I wouldn't say no to acupuncture, but I'd want you to, believe in what they're telling you, and I wouldn't spend lots of money on it because, most people doing acupuncture are private because there's not much of it on the NHS. So, so you can try it. Osteopath twice. This is a bit more bulging discs and narrowing of C5 nerve. The catch with that is, if you're seeing a very, very good osteopath, they wouldn't do the wrong things. So then there's no problem. But how do you know they're a very good osteopath or very good chiropractor? Because I've seen in my practice people who've seen osteopaths and chiropractors who've done things to their neck when they've had a C5 nerve root narrowing and they've turned it into a complete and C9 root compression. So I've seen people made horrendously worse by seeing someone who wasn't skilled enough. So I would, a bit like the neurologist, I'm a bit more cautious, and it's not because I'm a physio, because I treat necks. But if you've got narrowing around a C5 nerve and 2 discs bulging, you've got to be careful that whatever treatment the therapist, physio, osteopath, chiropractor does, doesn't make those discs rupture and squash the nerve, because then you're in a far worse situation. So if the osteopath is someone you know really well and they're really good and they wouldn't do the wrong thing, that's okay. But if you can't answer that, I probably wouldn't see them.
Yeah. I'll just ask Richard's final question was about
the first question. That's a bit harder.
VRT. He says, I've got VRT and have recently had intensive balance testing done. I failed most of the tests as I was falling to one side and couldn't multitask. I've been told I've got chronic vestibular migraine, a form of many ears, and triple PD. Where do I go from here in terms of further VRT, and how do I move forward to live a more complete life with these conditions?
So that, again, that's quite hard, because the thing is, I don't like the word failed most of the tests, because that implies you've done something wrong. And it depends what the tests were, because with vestibular function testing, you don't fail them. What happens is we're looking for something. We're looking for something that happens. So if, for example, if you've had a caloric test where they put the hot and cold air or hot and cold water in your ears, you don't fail that. It can make you, it can tell us if your ears are out of balance and how much percentage they're out of balance. But it only tells us on one of the spirit levels. I mean, there's 3 spirit levels, three semicellular canals. The caloric test only tests the lateral one. So we can get an indication of its function. So you don't fail that. The vestibular function test, we look at eye movements, we're recording eye movements to what happens when the tests are going on. So we can make a judgment and have an idea of what systems are involved. But the tests themselves are not specific for any diagnosis. So there's no specific diagnostic test for Meniere's disease. Meniere's disease is diagnosed by what the patient says. And then after a long time, the audiogram, the hearing test, will show the lower frequencies on one ear are different to the other. But people with Meniere's will describe attacks of vertigo, a fullness in their ear, increase in tinnitus and hearing loss, all at the same time. So that is far more diagnostic of Meniere's disease than any test, because if you had a test and you've got Meniere's disease and it's early Meniere's, your hearing will go back to normal. So if the test is done 5 months after you've had a Meniere's attack, for all intents and purposes, all of the tests could be normal, but it doesn't mean you haven't got Meniere's. And then the other things, migraine is again diagnosed by your description of symptoms. So you're describing a sensitivity, whether it's light sensitivity or hearing or smell, those sort of things. And then chronic vestibular migraine is interesting because it either means you're having a migraine the whole time, or you're a migraineur. So that does need treating, but the treatment for that is usually medical, to have some sort of migraine prophylactic treatment. And then PPPD is this, it's a relatively new label that's used for a combination of symptoms. So it's, I often get it wrong now, persistent perceptual postural dizziness. And it's a label that's come about to cover a set of symptoms when people who've had symptoms for a long time often are hypersensitive to motion, and they feel like they're moving, or they feel like they're moving much more than they are. So triple PD covers that, and people develop it. Their system, meaning their brain, becomes hypervigilant to motion. So any small motion is the brain overinterprets it. So you've got a system that is hypervigilant to motion. So all of those 3 things can overlap what you've got there. So, and vestibular therapy can be good for triple PD. It's not so good for acute Meniere's or acute migraine. It can help chronic symptoms from those. But with triple PD, often medication's needed to dampen down the hypervigilance of the brain. So a mild antidepressant, an SSRI type medication, can be used to dampen down the hypersensitivity of the brain, and then exercises can help. So it depends if the team's looking at doing all those things. It's always hard when it's not our clinic's patients necessarily, because I don't want to criticize any other treatments that are going on, but all of those conditions can be treated, and sometimes the treatment overlaps. But if it's a form of Meniere's, it probably means it's more vestibular migraine. So the migraine needs treating. It means looking at your quality of life, making life changes, your dietary changes like you do if you have normal migraine, and then a migraine prophylactic. The only thing is, classic migraine often takes strong painkillers. With vestibular migraine, often pain isn't the symptom, it's vertigo. So painkillers wouldn't make any difference to that. So you don't need the normal over-the-counter migraine relief tablets, because they're aimed at the severe pain from classic migraine, as opposed to vestibular migraine.
Richard, does that help? Because that's a lot of information to take in.
Yeah, it helps. Yeah, I've got like a neurologist, ENT, vestibular therapist. I've got social worker, support worker.
Oh, you've got lots more than a lot of people. It's good.
Yeah, I've got the mental health issues on top of my vestibular disorders. So I've got all the anxiety disorders on top.
Yeah, but that doesn't help, because sometimes the treatment for triple PD can make you move, and that might then provoke some of the triple PD symptoms, which then might make your anxiety worse, which then sets off a vestibular migraine. So it's looking at how they all fit together. But if it sounds like you've got a full team of people there, you've just, all I can end up saying is movement is good, even if it feels wrong. It's just got to be controlled.
Yeah, I walk like an hour and a half a day over 3 walks with the dog.
Good, that's good.
But on the balance test, when standing on one leg.
Yeah, don't quote me to your therapist, but I don't quote that as a balance test. I mean, probably, you could go and get, 100 normal people without problems and get them to stand on one leg, and they'd have problems. But the thing with standing on one leg, if you did it every single day, 3 or 4 times a day, standing on one leg, you will get better at it. It's as simple as that. I fractured my ankle. I can't stand on my left leg for more than 10 seconds. Now, if I practiced it every single day, it would get better. Do I do it? No, because it doesn't create a problem for me in real life. So I haven't got the incentive. Now, all of the people here on this forum, that's why they do vestibular exercises, because you've got the horrible incentive of the vestibular problem to make you do the exercises. But standing on one leg, how often do we have to do that? I mean, that's how I dislocated my ankle in the first place. So I could get better at it, but I don't do it. I probably should do it a little bit, but it doesn't create me a problem. So I wouldn't be worried that you can't do that. But the walking in the dark, I would use that as an exercise somewhere really safe, or walking on the spot in the dark, because that's a good vestibular exercise. It's really good. As long as you're safe, doesn't matter where you end up, but it's a good, and the more you do it, you'll get better. Your vestibular system will like it.
Brilliant. Look, Andrew, thank you for that. And Richard, thank you for all your questions as well. I'm not sure, I can't see Narendra anywhere. I'm not sure he's here, but he's put a question in. He says, after losing my hearing in I think it's my left ear 6 years ago, I was referred to physio at the Royal to cure my imbalance after nearly a few years of doing physio exercises. 80% of my balance has returned, but I still suffer. Is there anything else I can do to improve my imbalance?
Well, the thing with that is, so it sounds like there's been a big vestibular event, 5 or 6 years ago that's done the damage. So the ears have gone out of kilter. And as I said earlier, my target in my mind, when I see a vestibular patient, 80% is the target I'm aiming for, an 80% improvement in their function, whether balance function or reduction in symptoms. So in that sense, he's got to the figures that we would be aiming for. Now, obviously, when people improve to a certain level and they're not right, they always want more. Now, there's nothing wrong with that, but I've had patients at the Royal say they're 95% better, but they want the last 5%. I've had one gentleman in Warwickshire who was 99% better, but he wanted that last 1%. So the bottom line is, whatever that 20% is, or whatever that 5% is, or that 1%, whatever that is that's making you think, well, I'm not right, I'm only 80%, that 20% or that 5%, that's what your exercise should be. Whatever it is that is challenging, as long as you can do a safe version of it, that's what you should be using, because just doing some basic balance exercises might not get you past the 80%. It's got you there. To go further, you might have to be doing, I've had someone who wanted to get back to doing slacklining, which is like tightrope, but it's on a slack line. It's sort of wider than a tightrope, tightrope, but it's about that wide. It's only about 2 feet off the ground, and it's really slack, and they walk on it. Well, that's what they couldn't do, and they could do it before they had the vestibular problem. And so when they were 90% better, that's what they couldn't do. So guess what their exercise was? That was their exercise. They had to use the problem to get better at it. And so, because people often avoid the thing they can't do because it creates a symptom or isn't right, so they avoid it. And wait for it to get better. Well, slack line walking isn't going to get better if you're not doing it.
Yeah.
And I would break my ankle if I tried it, so I'm not even going to try it.
No, I'm not going to try that. But even, little things like the stairs, I've avoided stairs for years, coming downstairs. Going up is not so bad, but coming down them. Got a new job, and my office is actually upstairs, so I've been forced to do that. And that is
better.
It has.
Yes.
Coming down is still a challenge, but trying to, hold a cup of tea or more than one cup of tea.
Yeah, see, that's it.
That's going up is really hard. And coming
downstairs holding a cup of tea is a really hard balance activity. Really hard. So I would say, when you get good, you'll get better at it. Because I see so many teachers with vestibular problems, and they often work in schools with really open staircases with the students and things, and they have challenges with it. But because they have to do it, they get better at it.
So keep at it.
Yeah.
Brilliant. All right, Kate's got a question as well. My balance is slowly getting worse. My latest diagnosis being I now have an essential tremor and could be linked to my balance. Should I be seeing a balance physio, she asks, or are there home exercises I could be performing rather than seeing a therapist?
Well, if you haven't seen a physio at all, yes, I think you need to be seeing someone, because having an essential tremor can influence the balance. It shouldn't relate specifically to a balance problem. So having an essential tremor might influence balance, but it wouldn't be a balance problem causing the essential tremor. So it needs to be under some sort of health professional who can understand and look at the balance and look at the essential tremor and see what the link is. Because we don't know there's a vestibular element at all there, because balance is the end result of everything. It's the result of the ears, your eyes, your brain, your body, and I'm only saying this because I don't know, but for example, if you had diabetes and you had a peripheral neuropathy, which was slowly getting worse, that will make your balance worse. So that doesn't mean doing vestibular exercises will make 1% a difference to that, because the problem's due to not being able to feel the feet properly. So it depends what's going on. So you need to be seeing someone who can direct you to see whether they're linked or separate and what you can be doing. But the bottom line is that any balance exercises are good in small amounts, because anyone's balance can get better with repetition.
Okay, great. A couple of final questions then that have been sent in. I have Meniere's, don't know who this is from. I have Meniere's and occasional violent vertigo attacks with vomiting for up to 2 hours. I then normally have to rest for 24 hours to recover and get some basic sense of balance back again. Not sure after such an attack when it's a good idea to start trying to train my balance again, as I do worry if I do it too soon after one day, I am just putting myself through unnecessary, horrible sensations for no benefit. How do I know when to start trying balance rehab after an attack that will actually be effective?
Well, the thing with that is, yes, so when you have a Meniere's attack and it's a violent vertigo attack and you're sick, that is quite horrible. So if you're only having vertigo attacks, I say only, having vertigo attacks like that, if they're spaced out, like every, 4 months, so say 3 attacks like that a year, if you're better within a week without doing any specific exercise, you don't need rehab, full stop. And there's no point in trying rehab one day after a Meniere's attack. People who have standalone violent attacks of Meniere's, but then go back to relatively normal before the next attack, don't need rehab. Rehab works when they've had Meniere's for a long time, and basically after each attack they lose a little bit of their function, and then another attack and lose a bit. So after a set time, maybe 2 or 3 years between the attacks, they're not right. That's when rehab works. And then it works whether it's 5 or 6 days after an attack. They know when they can start exercising, and then they can do it. And yes, it might not feel right, but it won't make them feel as bad as after an attack. So I hope if they're online when they hear that now, so after a Meniere's attack, the rehab exercises are not going to help immediately. And most people who have Meniere's know when they can start doing something again. It might be 3 days, 4 days, 5 days, 6 days, something like that. But if it's longer than 7 days, then you're saying, well, yes, rehab would be working because they're not getting back to normal after the attack. So I use that sort of, if it's quite a few days, then they can start a rehab program gently. And the exercises, as I said earlier, should not trigger a Meniere's attack. So if they do it too soon after a Meniere's attack, they won't like doing it because everything's a bit hyper and everything's a bit horrible. So if you've had a Meniere's attack, recover from it over several days. And then if you need rehab, because rehab takes a minimum 6 to 8 weeks to start making a difference. It takes that long for the rehab. So the rehab doesn't work in a week. So if people start rehab and they're better within a week, I'll be saying, well, it's not the rehab that's made them better. They've got better. You know, the exercises didn't do it. They got better. The exercises take 6 to 8 weeks minimum to start recalibrating the inner ear. And it takes 3 to 6 months for a much longer term effect. And if you keep having attacks in that time, you keep resetting that time frame, which is that's the nuisance.
One final question then, and then we'll go to everyone in the meeting today. How important is it to have a diagnosis before attempting various rehab, self-treatment or professional treatment? Can it be harmful to have the wrong rehab exercises?
So again, it's difficult to answer, like with an anonymous thing there. It's important having a diagnosis so you understand what's wrong with you. As a patient, having a diagnosis is important. There aren't really any wrong rehab exercises. You can do them wrong, or they can be wrong for that point in the rehab. So doing fast head movements the day after a Meniere's attack is wrong because they'd hate it. It'll probably make them be sick. It won't be dangerous, but it'll make them feel so ill they'll never ever choose to do that again. So it's wrong in the sense like that, but it's not dangerous. The wrong exercises you can do are if you've got BPPV and you treat the wrong ear. So if you think you've got right BPPV and in fact it's left BPPV, so if you look online and do a right epley off the internet and in fact your problem's on the left ear, when I say we're tipping the crystals into the right place, these are mirror images of each other. So if you think it's in this ear and they're in this ear, and you're doing a treatment for this ear, for the BPPV, you might be tipping the crystals completely into the wrong place. So once again, that isn't dangerous, but it will make you feel really bad, potentially. It might make you sick. And it might put you off doing things. So it's the putting off or influencing you. The only risks is if you're more elderly, when I say that. Some people are really off balance if they've got crystals in the wrong place, and they might, fall off a curb or fall off the bottom step, and they can hurt themselves. So it's all of those things, but the exercises themselves aren't dangerous. But if you make yourself really wobbly, then try and do something dangerous, that can be dangerous.
Great, thank you, Andrew.
So I would like a diagnosis so you understand it. And then self-treatment, movement is good normally. I mean, so as you heard all along, the vestibular system uses movement to retune. So movement is good. And when it's not working properly, it stops you moving because you don't want to move because it feels wrong.
Andrew, I know we've got questions. Kelly's been keeping across those.
I was hopeful there wasn't.
Kelly, it's over to you.
Let's have a look.
Okay. I've got a couple from Deborah. Deborah, would you like me to ask the question, or would you like to ask the questions yourself to Andrew?
I don't mind asking.
Go for it then. I love your questions, by the way. They're definitely things I can relate to.
What I wanted to know is, when we get tired, why does that make the dizziness worse? Is it because our brains haven't shut down? They haven't had the chance to rest?
Well, it probably is that, but I mean, so in a way you answered that yourself. But if you look, when you've got vestibular symptoms and you're not better, in quotation marks, whatever that means, and better means that you're not really aware of your symptoms and not having to do rehab. So that might be 6 months down the line. So when you're in the stage of doing rehab, the process of feeling better is an active process. Your brain has to actively balance your ears. So your ears, one ear's damaged, so electrically your ears are out of balance. With rehab, we're making your brain see your ears the same. That's what's happening. It's not fixing it, it's not curing it, it's electrically retuning it. So it sees this, but in real terms, that's what's there. So for your brain to do that is a very active process. Your brain has to put a lot of effort into doing that. Even if you're feeling quite good, your brain is actively doing it. So if you're really tired and really fatigued, your brain just can't do that and goes back to that. Your brain sees that and that gives you symptoms again. So when you're really fatigued, you just have to respect that and rest, because so you can recharge so that your brain can see things like this again. Because if you keep then trying to work and do something or keep walking or go for a run and it's like this, it will be much harder and everything will work harder. And so the fatigue will be worse, you'll be more off balance, your muscles will work harder because things are out of kilter. So therefore the fatigue will get worse and you'll feel worse. So we'll just change place. You shot across my screen to the left. So I sort of hope that answers it. So you have to respect fatigue. And the worse you are in symptom wise, little things will fatigue you. I mean, the better you are, it'll be, it might take more to fatigue the system, but then you still got to respect it when it's there. And the same applies to stress, worrying about something, anxiety, and if you get ill, any viruses, you might have a minor virus, not COVID or whatever, just a minor cold. Your brain can't actively sort your ears out if it's worried because your tummy's upset. So once again, your ears go from that to that, and that's why people can have a tummy upset and the balance symptoms get worse, because the brain, when it's working for you, it's an active process. And until it becomes hardwired, which is what we're aiming for, so we want that to become hardwired, that your brain is doing that, that takes 6, 8, 12 months for that to occur. So while that's occurring, lots of things interfere.
Thank you. And my second question was, if you're going to go on a long haul flight, have you got any tips that can reduce the dizziness, please?
Well, the actual long haul flight itself, probably, unless you've got, if I say barotrauma, meaning pressure related damage, so you've been a scuba diver and it's damaged your ear, the actual flight itself shouldn't cause the dizziness. If you're travel sick, that might be worse on a long haul flight. So over the wing, by the window is normally the best place on the plane, because that moves the least and you can see the movement. Taking travel sick pills can help. Making sure you equalize the pressure, whether you're chewing or Valsalva maneuver or popping your ears, that can help. But lastly, a lot of people that feel worse on the plane, it's not the plane, it's the airport before the plane. It's the queuing, the stress of insecurity, standing up in a close queue, getting worked up, going duty-free shopping under bright spotlights with all the colours and excitement and the crowds, and then running for the gate because you're late and queuing. All of the stress, that then creates the symptoms when you're on the plane.
Right, thank you.
And also long haul is often better than short flights, because say flying from here to Scotland, the plane sort of goes up and it isn't up very long before it's coming down again. So the pressure change is quite dramatic, up and then down, as opposed to flying across to America, that once it's up, you're staying at the same altitude all the way across.
Thank you.
Obvious. Deborah, if it's helpful, I found when I've travelled on a plane, if you ring the airline before you travel and just sort of explain that you've got this balance condition, they're really helpful in terms of putting extra things in, so getting you through, like some of, as Andrew said, the busyness parts, you know, when you're at the airport checking in and departing. I had things like put into place so that I could bypass some of the queues, so I got taken straight to the queues for security and passport checks, so that you didn't have to deal with all that busyness. So I'd recommend speaking to your airline if you've not done that before.
Okay, thank you. Yeah, thank you.
Any more questions, Kelly? I think we've got one or two.
Yeah, there was one from Lena that we were having a bit of a discussion about, and is it Lena? Do you want to ask your question to the group about the identification? I know we talked about the sunflower lanyards, but I don't know if anybody else knows of anything else.
Yeah, can you hear me okay now?
Yes.
I've got a new mic, so I don't know if it works well. Hi, Andrew.
Hello.
Basically, you know, if you're a blind person, you have a guide dog or you have a walking stick. So like when you're walking down the street or trying to cross the road, car drivers, normal car drivers would see you and be a bit slow driving past you and stuff like that. I found a couple of times, because I don't have anything like that, and if I'm walking and my balance is a bit off, I'm walking a bit slower. I don't even have any sticks either. I just walk slower. Mm-hmm. And if I get to the road and it's like a constant left and right, obviously that messes up the BPPV. But it's like, is there anything visually that we as people with balance disorders can wear or have, or just to let other people know that not to honk quickly and, you know, whiz past and stuff like that?
Well, no, it would take something like this group to develop something like that, because you could, I mean, I know the Meniere Society have Meniere's t-shirts, but not to say they've got Meniere's, but like supporting the society. But you could look at, as a group, developing something like that, because I can hear what you're saying. So the answer is, other than having like a lanyard, which people have for not wearing masks, so there's a lanyard for people to wear at airports to say that they haven't got a visible problem that will need help. So the airports know about those. It's got like butterflies on, so it means if they're looking lost, airport staff will actually go over and see if they need help. But that wouldn't help you in the street, because but if that's the sort of thing you might need to do. Even though you don't want to hear this next statement, sometimes having like walking poles will at least tell the driver there's something wrong.
Yeah, I've never used them.
I know, but what I meant is, having the poles means at least that they recognise, oh, that person's got, they can't rush across the road. Whereas the other things are all obvious things, but there isn't. So the answer, there isn't something for you at the moment. You can develop something, and then some charity would take it on and make them, but it depends. Ages ago, I did a little mini survey at work. I mean, it was years ago, and I asked my patients, if we had a t-shirt designed saying, I'm not drunk, I've got a vestibular problem, would they wear that? Half the people thought it was the best idea ever, and the other half were absolutely horrified, and they would never wear it. So it's that sort of situation. So, what would you wear? Do you want a big vest saying, I've got problems that you can't see? What? So you got to look at it. Do you make it humorous? Do you put something on it? So that's something you guys can come up with. But so at least having poles or a walking stick indicates there might be something, mechanically wrong with you. The lanyard is good at airports, but on a road people wouldn't see it. So I asked you, Lena, would you wear the t-shirt saying, I'm not drunk, I've got it? See, you would. You would wear something like that.
Yeah, I would. I mean, because I know I had an alcohol problem years ago.
Oh, I'm not going into that.
I don't drink anymore.
So yours would be, I don't drink anymore now. I used to. But
can I just ask? Sorry.
I was just about to say, Kevin, this is one for discussion again, I think.
But it is something that we look to be developed, because your group
our very own life on the level kind of, I think
that's
identity.
A brilliant idea, really.
Yeah,
I'm working on the design already.
I can imagine. He's the
jagged
right
lines
man.
that really put people off.
Can I just ask one quick question now? I can't remember if I mentioned this at the last meeting I had with you, but I've found I've been chatting, their family are not very supportive. Yeah. Now, you've always told me every time I do an Apley maneuver, I'm supposed to stay upright as much as possible for 3 days and 3 nights. And obviously with me, I get totally exhausted because I can't sleep. I'm awake all night. So one of my sisters came knocking on my door one day, and she says, what's up with you? Because I literally look like I'm now death awake kind of thing. So basically she said, what's up with you? I said, oh, I've just had the Apley maneuver. I haven't had any sleep for 2 nights. And she goes, oh, that's bullshit. Well, sorry, my French. That's actually what she said. That's BS. I just had one of those and I was lying flat on my bed the first night.
Well, there is, in the literature, there is different information. So because in our clinic, we all try and say the same thing, so you don't get mixed messages. If I tell you one thing and if someone sees Michaela and she says something different, then Professor Ray says something different, we don't want that. So we all try and say the same thing. But the bottom line is, it makes sense with your inner ear that if something's done to it afterwards, we don't want you lying flat because it just might tip it out again. So it makes, if I say, sense, but in the scientific research doesn't support that. It's on the fence. So I now tend to say, and see, you haven't mentioned it to me when we've had our last chats, sitting up is really hard. Sitting up, sleeping sitting up is really, really hard. And most people end up like that, which is just as bad as lying down. So you know, I think maybe Michaela says as well, we say sleep propped up with, you know, several pillows so that your top half is propped up, but you needn't be sitting. Is that right, Michaela? I'm looking at Michaela, yeah. So I know Professor Ray still says sitting, but we say propped up. But if you were in Sweden and had the Epley manoeuvre, yes, you're allowed to sleep lying down immediately. So in Sweden, if you had it, and it's not because Swedish people have got different inner ears. And in fact, I have had one patient, and I hope she's not online. I can't remember her name. So as long as she doesn't identify herself, it's only her problem. Who I always used to say, use 3 pillows after you've had an Epley, and then you know, so 3 pillows, so you're propped up. And then next time I saw her, I said, a lot of people say that, you know, sleeping with 3 pillows hurts your neck, and she goes, no. She said, why would it hurt my neck? And I said, well, people complain. She says, I put them under my feet. So after the Epley with me, she went home and slept with 3 pillows under her feet. So she was tipped up after my Epley. And I said to her, why did you do that? She said, I don't know. And I said, did you do that last time I did an Epley? She said, no. So she said, oh, don't tell anyone. I said, I can't make that promise. I said, what I can say is I won't tell anyone your name. So, but no, so she slept tipped up and he didn't tip the crystals out. So in a way, if they're going to come out, they're going to come out. But it does make sense if you can sleep propped up, at least for a couple of nights, it gives it chance to settle back down into the right place. If you can't, why not try it rather than that? Because the feeling awful afterwards is the main, in the literature, when they did a study on it, what you're saying is what most people found. They couldn't do it because it made them feel so horrible. So why don't you try sleeping on several pillows, not propped up, and see whether, I mean, propped up, but not sitting up, and see if it makes a difference.
Thanks, Andrew. I know we've got, thank you, Lena. Andrew, I know we've got a few more questions to get through. Kelly.
There's one next one's from Naomi. Would you like to ask that, Naomi?
I need the dog barking. Right. I can't stop my dog, so because my mic's on.
Oh, don't worry. Naomi, I'll ask your question for you then.
Yep.
So Naomi's asked, what are some basic and safe exercises for vestibular migraines? She's had it since 2019 and never been given any physio.
Okay. I'll just see why the dog's barking before I answer that. I'll just have a look. See.
So we'll just talk amongst ourselves in the meantime. Can I just?
No, I was just looking out the window looking to see why. It's all right. I was
just going to say, Andrew, that there are lots of really helpful links that Kevin and other members are posting on the chat group as well. So if you want to save the chat, there's.
Well, the thing with that, the bottom line is with vestibular migraine. So yes, with vestibular migraine, the biggest thing is the exercises aren't for the migraine. You have to treat the migraine. And so the migraine has to be treated. And then any vestibular exercises are okay, but less of the visual ones. So, the less visual, we don't want anything visually to stimulate the migraine. But as I was saying, gentle head movements with eyes closed is a good one to use for vestibular migraine, but the migraine has to be treated, because the exercises don't treat the migraine. That's, I suppose, the big thing that's important to say.
Thank you, Andrew. Tracy, thank you. You've got to disappear. Really appreciate you being here today. Kelly, I know there's a couple of more questions.
Yes. Amy, do you want to pop your question out?
Sure. I mean, your last answer might have answered mine as anyway, but as part of the vestibular migraine, I get pretty much constant interictal dizziness between attacks. I was wondering if rehab exercises would have any chance of helping with those. On the medication front, none of them are really working much for me. I'm trying Botox in July, but so far things just help a little bit for a little while and then stop working. But
okay,
so I'm looking for other things to try.
It depends how often the migraines are happening then. I mean, how often?
A lot of the time it can be daily. At the moment, the Meniere's attacks maybe the big Meniere's attacks are maybe once or twice a month, and the big migraine attacks are usually a few times a week, but I have constant dizziness in between as well.
See, it's hard for the exercises to help that, because the attacks are so frequent that the inner ear function keeps fluctuating with the Meniere's and then with the migraine. So you've got to find what helps you. So I would be saying doing things with your eyes closed, gentle, slow movements with your eyes closed.
If the Botox works and it controls the big attacks, and then I'm hoping it will also help the Meniere's attacks, they both seem to feed off each other. Will the constant dizziness in the middle be helped by rehab exercises?
Possibly,
then? Is it worth?
Okay. Yes, it is. And the other thing which I think is important with migraine people to say is they often haven't. You've probably been told about dietary triggers. I assume, in your diet which trigger things. When attacks are so frequent, sometimes there's something in your diet which isn't one of the classical migraine triggers that's causing the problem. So I would always say do a migraine diary, and you do a diary of everything you eat, and you're writing down your symptoms every day, and then you cut out lots of different things and look to see if the scores change. Because there might be something in your diet which is a trigger that no one's mentioned to you, could be a trigger, in such things as walnuts, avocado, banana, egg. So they are not classical migraine triggers, but when I've had people do migraine diaries, they've suddenly found that they actually have, because they're still having lots of eggs or they're still having lots of avocado, and then when they cut that out, the frequency of the migraines change, and then all of those over ramping up, which is what you've got, was more controlled.
Okay, thank you.
Thank you, Amy. That was great. I believe I've got one more person down on my list as having a question, Rupert, but I don't know if you know anybody else. But John, are you got a question, I believe?
Yeah, is that me? John Abbott?
John Abbott, yes.
Yeah, all right.
Go for it.
Yeah, well, I think part of my question was answered before, because I've got a similar problem to what Alison Nugent's got with the bilateral vestibular failure. So what I just wanted to clarify of Andrew was, he mentioned about you can't give specific exercises for it. So is going about my daily life as much as I can the best I can do, really?
Well, yes. You can't give specific exercises to deliberately make the brain do what we want, but the more things you're doing gives it chance to work.
Yeah, I understand. That's what I'm trying to do as much as I can.
Yes.
Because the worst thing for me is the oscillopsia.
Yes.
Now bounce, and that's one of the worst things. But I do drive, although I have to concentrate really hard. I do drive. I had caloric testing and vent testing, and I was just told that I had total stroke, almost total bilateral loss.
Now, okay, see, there's a difference between complete failure, because with complete failure there is no VOR, and that's why you've got the oscillopsia. But if it's almost complete failure, if there's some function, your therapist should be building some sort of normal rehab in as well, because if there's some vestibular function, the brain can use that. So whereas the last lady, I can't remember her name now, she knew there was no function. So So it's just worth, if there is a little bit of function, it's worth trying some normal rehab as well as the other things you're doing.
So if I had some function left, would I still have oscillopsia?
Yes, you can still have oscillopsia, but that if there's some function left, you'll be able to, for example, you can do it with Nia. If you look at me on the camera, and if you move your head left and right, can you keep me on the screen?
Yeah.
Yeah. So if you had no function at all, you wouldn't be able to do that.
Right. Yeah. I have been doing my VAR exercises for, 12 months, looking at the target and keeping it in focus and going faster and faster. But
don't go bigger and bigger though, because you were going quite big. Don't go big, but the fact you can do it, if you had no VOR, you wouldn't be able to do that, full stop.
Right. Okay.
So there might be a little bit of function, so it's worth working on that.
Yeah. All right. Thank you for that. Appreciate it.
Brilliant. Thank you for that, John, and thank you for that, Andrew. I think we're done on the question front.
I've got a question.
Go for it.
I just suddenly remembered because driving has been a thing. I'm great driving normal daytime, locally, not a problem. Getting onto sort of A roads or the motorway, I really struggle with that. Is there any advice in terms of doing any exercises when it comes to move when the traffic is going at a higher speed? I struggle with that. Is there any advice?
The two ways around that, both are challenging though. One, you need to do a little bit of it when you're in control, because at the moment you probably only do that because you have to go from point A to point B for a reason. So when you do it, you can't afford to feel ill, you get you worked up. So you need to start doing it when it doesn't matter. So, and you might need to do one junction on an A road and then come off. So you start getting used to it. Because otherwise, if you have to go to meet someone in Derby at a set time, then, if you feel strange, it just ruins it for you. Whereas I'm saying you need to start doing a little bit of it somewhere safe, somewhere quiet when you're in control with someone else in the car, so that, you can't, but it's actually doing it. Two, you have to try and find either computer game or YouTube video that you can watch that gives you the same sensation, and then you can watch it in the safety and then watch it to get used to the stimulus.
Okay, that sounds awful, but
I know, yes, it is. And that's because that's one of the hardest symptoms to treat.
Yeah,
for that reason.
Just a supplementary question, again, driving in the dark.
Yeah.
Really struggle with that.
Yeah, that's because all these bright lights are really, and I know with your, there's a migrainous element, so that's got to be careful with the lights. That's a bit harder, so I wouldn't say straight away doing it, but you can get night driving glasses from Halfords for night driving, and that can sometimes help. They're bright orange ones that wrapped around. Some people have found those really useful for night driving.
Oh no, everyone's frozen.
Did you hear that? No?
Hello?
Rupel's frozen.
Rupel's gone.
Rupel's gone.
Come on, Rupel. Come back. Hopefully, Rupel. Yeah. Oh. You're back in the room, Rupel.
Oh, I missed that. Yeah.
Oh, no, I'm not saying it again.
Just froze on me. I'm like, no.
No, you froze on us. Everyone else was moving.
Rupel, you'll have to watch the video.
I will watch it back. Thank you. Never mind.
Cool. Any more questions for anyone? Are we all done? Kelly, is that, yeah?
Can I ask?
One more.
Debbie?
Just quickly, when you say those orange glasses at Halfords, are they FL41? Are they the same?
Oh, I don't know that.
Okay.
They're called night driving glasses. So they're not for people with vestibular symptoms. They're for people who find motorway driving at night a problem. So whether they're the same as what you said or whether what you said is something different, I don't know.
Okay.
Yeah, I believe they're different, Andrew. The nighttime driving is not the FL41s. It's more about blue light, I believe, on there.
Yeah, so if it's migraine, are the FL41 for migraine?
Yeah.
Yes, because they'll be cutting the blue light, because with fluorescent lights, which is what they're to be worn under, it's often the blue light that triggers migraine. So the FL41s are filtering out the blue light. The night driving glasses are orange because it's the halogen headlights that they're supposedly helping with, but lots of lights are now LED lights on cars. So I'm not sure whether their night driving glasses work the same for them. So I don't know.
No, super. Good. I think we all done. Yeah. Okay. Brilliant. I've got to say, big thanks, Andrew. That, by the way, I thought was the best explanation I'd ever heard on BPPV.
Oh, was it? Oh, okay.
Yeah, and I think I might be able to edit that down and make you a TikTok star.
Oh dear, I've never even seen TikTok.
And if that
if I had a diagram,
work,
it's even easier.
But if that doesn't work, we're going to do the one where you're shaking your head violently.
No.
That's got to be good. So just quick reminder to everyone, June the 18th is your next meeting. We're talking about coping with, dealing with anxiety when you've got a balance condition. Andrew, you're such a star coming on today. The feedback I've been seeing has been wonderful.
Oh, that's good.
Been helping so many people.
The rugby only starts in 15 minutes. Time to get downstairs.
We've timed it perfectly that you're gonna see everything. So thanks everyone for joining today. The video will be available shortly. You'll get an email giving you links to it. You'll also, on the same email, be able to download the chat transcript with all the links if you've not downloaded it yourself off Zoom. But thanks everyone for coming and taking part. We couldn't do it without you and your brilliant questions. It's wonderful to hear it. And remember, everyone who's asked a question, that will be a question hundreds of others will have in the future. So well done, everyone. So brilliant. Thanks, everyone. And we'll see you in about 8 weeks.
Thanks, everyone.
Take care.
Bye.
Thanks, Rupal. Thanks, Kelly.
Bye.
Thanks a lot.
Bye.
Bye. Bye.